Morning, everyone. I don't know if it's a blessing or a curse having Michaela getting the audience so excited before we even start. We'll see how it goes. But if this goes well, Michaela, are you available to be the warm-up act for all of my lectures for the rest of my career? Because you've really got everybody going, so that's brilliant. So Sue's asked Mona and myself to talk to you about waste of research. And this isn't intended to get you depressed before you even start the week. But really, it's something that we do need to think about. And we'll have a few little examples, and we'll have a little look at this. As we go through this, as you know, Mona and I are dentists, but please don't hold that against us. We come from a health background. So I'm going to illustrate with some sort of health examples. Most of these principles apply across the research spectrum, but inevitably we draw examples from our own backgrounds. So, looking at this opening slide, does everybody recognise this guy? Yeah? Name? Wile E. Coyote, yeah. Wile E. Coyote, and the reason I've put Wile E. here is because Wile E. Coyote, as you're probably aware, his ambition in life is to catch the roadrunner. And he seems doomed to failure. He repeats the same mistakes over and over again and never seems to learn from experience. Either that, or there was only a limited number of cartoons and I've just seen them over and over again. But it does rather seem to me that this is a guy who's not learning as he goes along. So that's the question we're going to ask today. Are we actually learning from our experience? And here's one of those made-up-on-the-spot statistics. According to The Lancet, it's been estimated that 85% of research is wasted, usually because it either asks the wrong questions, is badly designed, isn't published, or is poorly reported. Now, whether or not it is 85%, I don't know. It depends what you mean by research, and it depends what you mean by waste. But one thing that is true is that a significant proportion of research is wasted. And we're going to have a little look at some of that today. And if you're interested, you can go to this cunningly titled website, researchwaste.net. So it should be something that you can remember. And you can download a series of articles from The Lancet that cover a whole load of these issues around waste in research. And in particular, in this context, it's medical research. These articles are relatively recent, but if you go back a bit further, 20 years ago, a statistician called Doug Altman wrote an editorial in the British Medical Journal in which he complained about the scandal of poor medical research and how so much research is wasted. And only this month, in the British Medical Journal, in another editorial, someone was saying, quite sadly, it seems that not a lot has changed in the 20 years since Doug Altman first wrote this article. So, for some reason or another, we seem to still keep getting it wrong. Anyway, what are we going to do? So, Mona and I are a double act, so we needed to divide this up in some way. And what we thought we'd do is I'd take a high-level view of research, and I'm going to look at the kind of looking at it from above down, and Mona is going to look at some of the kind of specific issues relating to individual studies, a kind of micro level view of research waste, and we'll have a break partway through for comfort. So what am I going to do? Well, I'm going to start with what I think is the ultimate waste of research. And you can agree or disagree later. I'm then going to look at how do we know that we've got enough research evidence in order to make a good decision? point about doing research is to make decisions. You know, where I come from, that might be what's the best way of treating somebody. In other domains, it might be something else. But ultimately, we do research in order to help us make good decisions, or at least we hope. So how do we know that we've got enough good research to make a good decision? Then I'm going to move on and think not just, you know, have we got enough, but how do we know when we've got enough of the good stuff? How do we know that we've considered all the things that we need to consider in order to make those good decisions? And I'm going to finish off with a little bit of context where I come from about how we integrate research into making decisions in healthcare. As I go through, there's going to be a little bit of stats in here, and I realise I've got some people in the group who are into their stats and their maths, and got some people who come from a background that doesn't involve that. So that puts me in a difficult position to try and appeal to two audiences, and you can tell me at break later whether I succeed. I'm going to try to put stuff in for both audiences, but if I make a complete hash of it, let me know, and I won't do it that way again in the future. So the ultimate waste of research. What do I think is the ultimate waste of research? Well, coming from a healthcare background, I think it's reasonably true to say that throughout history, healthcare researchers or healthcare practitioners have attempted to do their best for their patients. Maybe not always, but generally speaking, that's what we set out to do. The catch is that there are sadly many examples of where harm has been done to patients because the decisions that the practitioners were relying on weren't informed by research evidence. So this skull here is a nice example of someone who's had a particular therapy that involved drilling a hole in their head. And that therapy has been used for all sorts of maladies throughout mankind's history. Some of which we might recognise and some of which we don't. And indeed, even today, my medical colleagues do still, sometimes on occasions, drill holes in people's heads. By and large, they have an evidence base for it now. And by and large, they're reasonably selective about when they do it. But that hasn't always been the case. And so clearly, if you have someone who has demons or something, and you want to drill a hole in their head in order to let the demons out, it is entirely possible that you may do them slightly more harm than good during the course of the procedure. So here's one such example. It's the story that involves a paediatrician called Dr. Benjamin Spock. And Dr. Spock, not to be confused with Mr. Spock, who clearly doesn't have a doctorate, not to be confused with Mrs. Spock. Dr. Spock was a paediatrician who was massively famous around the mid-20th century. This chap was probably the most famous paediatrician on the planet. And back in 1946, he wrote a book called The Common Sense Book of Baby and Childcare. And this book sold in its millions because he had a very simple message. And his simple message was, don't worry, Mum. It's not this huge, scary thing. It's perfectly okay. There's these simple, common sense things you can do, and your baby will be fine, and they'll grow up to be happy, well-adjusted people. And you don't have to get scared about it. And one of the pieces of advice that Dr. Spock gave parents, particularly mums, was whatever you do, don't lay your baby on its back when you put it to sleep. because common sense says if they then vomit or cough, choke, then it's entirely possible that they could inhale this stuff and they could die. And you don't want that to happen to your baby, do you? No. So don't lay them on the back, otherwise cough, splutter, choke, death. Okay? So mums all around the world said, right, fair enough, that makes sense, that's what I'll do, I'm not going to lay my baby on his back. And this guy was so influential that throughout the industrialised world, this advice was almost universally accepted all the way through to the 90s, to the 1990s. And as an example, by 1998, his book had sold more than 50 million copies and had been translated into 39 different languages. Massively, massively influential. This isn't the 1946 version of the book. This is the front cover of a later edition of the book that was published the year that I was born. And when I was putting the stuff together and sourcing this, I vividly remember seeing this book at home when I was a kid. I was my mother's first and remain only child, and she was absolutely petrified that she was going to do something wrong. Again, you can make your own judgment. So she, like many millions of other mothers, relied on Dr. Spock's advice, and I recall seeing this book about the house growing up. So that all sounds great. However, in 1970, good quality evidence emerged that said this advice is wrong. Nobody listened. Everybody believed Dr. Spock because Dr. Spock is the expert. Everybody knows Dr. Spock. He is the world's expert on childcare. So nobody paid any attention to the evidence. The scientific community ignored it, and it certainly didn't find its way through to parents. What's the consequence of that? This is a photograph of a TV journalist and personality called Anne Diamond. And Anne Diamond was incredibly popular. She was at the vanguard of the kind of development of breakfast television. Can you remember a time before breakfast television? So Anne was on one of the teams of one of the most popular breakfast television programs on the television. She was a journalist and a TV personality. And while she was on the show, she became pregnant and went off on maternity leave. And she was the nation's sweetheart, and everybody was absolutely fascinated. Everybody was absolutely delighted when her son, Sebastian, was born and came on the telly, and it was wonderful. 4 months later, Sebastian died suddenly and unexpectedly. And he died of a condition that we now call SIDS, or sudden infant death syndrome. And Anne and her husband, as you can imagine, were completely and utterly devastated by this. And like so many people, what Anne did was she said, I want to understand, it would help me if I could understand this. I want to understand why my baby died. And being a journalist, she did what journalists do. She investigated. And she found out that actually, as far back as 1970, there was good evidence that the advice that all the mums were being given was wrong. That actually you should lay your babies on their backs. That actually the babies are more likely to die suddenly and unexpectedly if they are not on their backs. So Anne did what journalists do, and she started a campaign. And she called this campaign the Back to Sleep campaign, back in 1991. And she used her public persona to educate parents and the health profession that the advice that they'd been relying on was wrong and out of date. Prior to her campaign, in the UK, the rate of sudden infant deaths was running at 2,000 a year. After her campaign, it dropped to about 200 a year. And in fact, she's the only person to have won a gold medal from the Royal College of Paediatricians for her contribution. She's the only person who isn't a doctor to have won a gold medal. This is the funeral. And the people who've done the stats have estimated that if we changed the advice to parents back in 1970, that across Europe, Australia and the US, we probably would have saved the lives of about 50,000 babies. So to me, the ultimate waste of research is when we do it and we ignore it. When we've got good evidence and nobody does anything about it, to my mind, is the ultimate waste of research. So, that's Anne Diamond. Which brings us on to this very esteemed looking chap. You can tell he's an intellectual by the way he's holding his glasses. This is Archie Cochrane. Could he have looked any more British? Look at that. Archie qualified as a doctor just before the outbreak of World War II. And he went off and volunteered and joined the Spanish Civil War that sort of preceded the Second World War, and he joined an ambulance team and was involved in caring for the wounded and the sick. And he had some pretty profound experiences whilst he was taking part in that conflict. Needless to say, lots and lots of the people who were dying weren't actually dying from the trauma of gunshot wounds. People were dying for all those other reasons that people die of in warfare, secondary infections and all sorts of other horrific ways that people were dying. And he said later, I knew there was no real evidence that anything we had to offer had any effect on tuberculosis. And I was afraid that I shortened the lives of some of my friends by unnecessary intervention. So he was there in the face of it all, and he recognised that so much of what he'd been taught as a doctor just wasn't working, wasn't right. And a lot of the things that he was doing with every good intention were actually not helping and possibly making things worse for people. And years later, in 1979, he wrote, "It's surely a great criticism of our profession that we've not organised a critical summary by speciality or subspeciality, adapted periodically of all relevant randomised controlled trials." And so in essence, what he was saying was two things. First of all, we should be using evidence as a basis for our decisions, rather than just what the experts told us. And secondly, that there was a real need to synthesise that evidence. If there are lots of studies that are being done on a similar area, we need to bring them all together. We need to pull them together in order to make the most use of them. And in 1992, we had the opening of the first Cochrane Centre in Oxford, and then actually the founding of the Cochrane Collaboration in 1993. The Cochrane Collaboration is a global initiative of people working around the idea of research synthesis within health to ensure that people involved in making healthcare decisions are making the decisions on the best available evidence, and that the evidence is pooled and synthesised wherever possible. So, if we're pooling this evidence together in order to make a good decision, how do we know that we've actually got enough evidence in order to make a good decision? So this is the stats bit, and I'm going to try and appeal to two audiences simultaneously here. So I'm going to do some stats, but I'm also going to try to provide a kind of plain language summary of what this is all about. So there is a statistical technique called meta-analysis, and it's a way of quantitatively pulling together the results of multiple studies. In my context, health, but it doesn't have to be health research. You can, if there are multiple studies that address the same or a similar question, there is the potential to pull those results together. And the reason for doing this is that often one study on its own might be too small to give you a reliable result, or even if it does give you a reliable result, it might not be generalisable. If you've done a study on a bunch of 18-year-old army recruits, that doesn't necessarily mean that you get the same results if you did it on a bunch of people in a nursing home. Okay? So the aim is to take this quantitative evidence, take these statistics, these data from studies that have all investigated the same association, and put them together in a way that we can provide a nice, clear, consistent way of summarising them all. That we can test an overall hypothesis, that we can estimate the average effect of the treatment or whatever else it is we're looking at, and that we can see whether or not the studies are consistent. And if they're not consistent, we can start to unpick why it might be that we get different results from different pieces of research. So the stats bit is, although there are myriad different variations on a theme, ultimately there are two main ways that you can go about this. One is by looking at all the data, what statisticians would call as a fixed effect, and the other by what statisticians would call a random effect. So, to illustrate that, and I'm sorry it's the middle, well, I'm not sorry it's the middle of summer, but I'm sorry that I'm using a Christmas tree in the middle of summer, but it's to do with clip art, and you will see what the clip art in a minute why. So, supposing we wanted to find out how tall a Christmas tree is, we could do an experiment. We could measure the Christmas tree using an appropriate measurement system, and we would come up with an answer. That will be our personal estimate of how tall the Christmas tree is. Then what we could do is we could ask a bunch of other people to do an experiment to measure the height of the Christmas tree as well. And they may all go about it in a slightly different way. But what we end up with is a whole bunch of different estimates of the height of the Christmas tree. My estimate, which obviously would have been the most precise and accurate, and then the other people doing their attempts. But they're all different estimates of the same thing, the height of the Christmas tree. And this is why I use Christmas trees. Because it is a different thing, everybody measuring the same Christmas tree, than to have a broader question of how tall are Christmas trees. Because clearly there's a lot of heterogeneity. Christmas trees are not all the same height. So when people go out and measure their Christmas trees, what we're getting are lots of different estimates. And it's partly down to the fact that everybody's measuring it in a slightly different way, but it's also largely down to the fact that all Christmas trees are not the same to start with. And I'll let you into a secret. Not all people are the same. So that's the difference between fixed effects and random effects. So if we were doing this in a health context, where we would probably be interested in people, but not necessarily, it's entirely possible that all of the studies might differ slightly. So the sample that people look at may differ. We could have young people, old people, different ethnicities, different gender distributions, different levels of severity of the disease that people are interested in. The treatment may differ. So if this is some kind of a drug trial, for example, it might be that one group uses a slightly different dose from another group in their treatment, or that they might provide it at different frequencies. So there are all these things going on that kind of muddy the water, this heterogeneity. So the idea of a fixed effect, if you like, is a kind of concept that there's one underlying truth, and that all of our studies are a different attempt to estimate that one underlying truth. Whereas in a random effects, that assumption isn't made. And we recognise that there may be different forms of heterogeneity in the system. So, for the statsy people, there's two pieces of information that we need if we're going to do this. We need an estimate of the average effect within any given study. And that's given by this symbol, a Y with a hat. A hat means it's an estimate, and we've got a subscript I, and that's the number of studies. So Y is the estimate of how good the treatment is in a particular study, and the I is the study it's in. So Y1 would be how good the treatment was in the first study, Y2 would be how good was the treatment in the second study, Y3 how good the treatment was in the third study, and so on. So we need to know how good the treatment appeared to be in each study, but we also need to see how much variability there is in the system. We need to measure how variable the results were in each of the studies. And with these two key pieces of information, we can do a bit of mathematical wizardry. And this is the basic equation, but there are variations on a thing. But basically what this equation is saying is our overall estimate of how good the treatment is the combination of how good the treatment seemed to be summed up, summing things up, over all of the studies and weighting them all so that they all contribute different amounts depending on how reliable they were. Or, if you prefer, what we're doing is we're sticking all of the results into a great big cooking pot and stewing them all up together in order to have, well, it actually depends, again, for those of you not familiar with the UK, stew if you're northern or common, casserole if you're southern or posh. So we put all the results together in a casserole in order to come to the overall combined effect of all of the ingredients. So, in plain English, what we're trying to do is we want to calculate an overall estimate of how good the treatment is. We want to include all of the relevant studies. We don't want to include them all the same. We want to weight them so that the more precise studies are going to contribute more towards the final answer, and the less precise studies will contribute less. And that is this concept of meta-analysis. The way that we present these results so that people can see them is through a thing called a forest plot. And I know Mona's mentioned a forest plot before, but I'm going to explain actually what it looks like And the idea of a forest plot, going back to the Christmas trees, is the idea of being able to see the wood for the trees. So what we want to do is we want the results of all of the studies, but we want to be able to see the forest, not just all the individual trees. It wasn't me that came up with the clever name, but I think that's quite sweet. So I'm going to build up the forest plot based on a meta-analysis that I did a few years back. And of course, because I'm a dentist, these are a series of studies looking at 2 different treatments for gum disease. And we measure how good the treatments are in terms of how deep the pockets are around people's gums. That was the outcome that people were measuring. So the first study, looking at this particular comparison of treatments, was a study by Altier et al. In 1979. And if we plot their results, we get a line and a blob. And the idea is the middle of this blob represents the average effect in that study of how good they thought the treatment was. For this purpose, but you don't always see it in a forest plot, I have made the size of the blob proportional to how much weight the study will contribute to the final answer. So the bigger the blob, the more it's going to contribute to our stew. The more of the ingredients going to go in. And the line either side of the blob is the 95% confidence interval. This represents our level of uncertainty around that estimate. So this was their estimate of the average treatment effect, but they were 95% certain that the true treatment effect is somewhere along this line. And that was the first study. If I do this, these are all the other studies that were done looking at the same treatment comparison. I've put on a 0 line here. What this means is that any studies that have results in this direction are tending to indicate that maybe the treatment group did better than the control group. And any heading in that direction are tending to indicate that maybe the control group did better than the treatment group. Does that make sense so far? Now, anywhere where the confidence interval, this line, anywhere where this crosses 0 is a non-statistically significant result. So the first study, the third study, the fourth study, and the fifth study, each on their own, did not produce a statistically significant result. The second study did, and actually we can see this is a very narrow level of certainty. This is a very precise study. It's going to contribute a lot towards the final answer. And this one, just about, just statistically significant. And when we put them all together, what we get here is our combined effect. So the blob is the average treatment effect, and this is our new level of confidence that we've got around the estimate. So overall, it seems that the new treatment was about 1/3 of a millimetre improvement in pocketing around your gums. So you know, you can go, whatever this treatment was, you can have this from your dentist, and on average, you'd be about 1/3 of a millimetre better off. Okay. Which is another important thing, actually. This business about effect sizes, you know, just because it's statistically significant, you know. Supposing this involved, I don't know, 27 appointments of scraping, and the control was, I don't know, being shown how to floss. You know, would you take the 27 appointments of scraping just to be 1/3 of a millimetre better off? Possibly not. That wasn't the treatment, it was actually an antibiotic study. But anyway, so that's what a forest plot looks like. So we have the results of each of the individual studies, and then what we have at the bottom is the combined pooled effect of our mathematical stew. All good so far. So that's how we know that we have enough data. But how do we know when we've reached that point? This is a paper from the Journal of the American Medical Association in 1992 by Antman and Lau. And what they did was they looked at all of the studies, all of the clinical trials that have been published looking at a particular drug called a beta blocker. And what they were interested in was people who'd had a heart attack. And the idea was people have a heart attack, and what do you do with them afterwards? And the theory said this drug could be useful. If you give people this drug after they've had a heart attack, they're less likely to have a second heart attack shortly afterwards. People who have heart attacks have a nasty habit of having another one quite quickly afterwards. And so the outcome of interest was whether or not people survived. And they were comparing this drug versus the standard treatment. And we can see that the first study was done in 1972. It just had 77 patients in it. And in this case, we're talking about risk. And in this case, 1 means no difference between test and control. So pretty much no evidence of any effect there. But over time, more and more clinical trials were done. And over time, the picture starts to build up. And we get down at the bottom. And when Antman and Lau put all the results together, for the total of 20,138 patients, they've actually ultimately got a highly statistically significant result here, 0.001. In this case, they've put the axes around the other way to me, so anything in this direction means that the treatment's better, and anything in this direction means the control's better. So by putting the results together of all of these clinical trials, we do have a statistically significant result. That's at about a quarter. So that means that people who were given the beta blockers, people who were given the drug after having had a heart attack, were roughly 25% more likely to survive and not have a second heart attack than people who didn't get the drug. So unlike the dental example, would you be willing to do that? Yeah, you know, so if somebody said, right, take this tablet after your heart attack, that's going to reduce your risk of death by 25%, you'd say, hand me the tablet, please. Yeah? So, by putting them all together, even though the individual studies might not have been convincing, the overall effect seems to show that it works. But Antman and Lau said, hang on a minute, this research was going back to the 70s. At what point did we actually know that this stuff properly worked? What if every time a new study was published, we combined the results of all the studies that have already been done with the new one? Yeah? So this is now what's called a cumulative meta-analysis. And what they've done is they've re-looked at the data and they've done a whole series of meta-analyses. Every time a new study was published, they've added those results to what was already known. And if we look at that, we see, so first study 1972, by 1977, we've got technically a statistically significant result after a total of 4 trials and 3,500 patients. But Did the doctors stop? No, of course not. By 1981, 7 trials, 6,237 patients randomized, p-value 0.001. This drug works. Did we stop doing clinical trials? No! 1982, 11,177 patients randomized. P-value 0.001. This treatment works. Did we stop doing clinical trials? No! 1988, 20,138 participants in, I don't know, lots of clinical trials. P-value pretty much the same as it was actually here. And at this point, people went, oh, do you know what? I think these beta blockers might be a good thing. What are the implications? Well, 1981, we had 6,000 patients and a highly statistically significant result. 1998, 20,000 patients, same result pretty much. Just from 81 to 88, that's nearly 14,000 patients recruited into clinical trials unnecessarily. Assuming half the patients got the test, half the patients got the control, that's roughly 7,000 people randomized to an inferior treatment that doesn't work as well. Now, one of the key ethical principles of doing a clinical trial is that you're not supposed to know which treatment's best. If you know which treatment is best and you randomize people to an inferior treatment, that's unethical. 10 extra large trials, what on earth did they cost? Lots and lots and lots of money, that's for sure. And who knows how many patients receiving inferior treatment? And that's just in the clinical trials. What about all the patients in the rest of the world who are receiving the inferior treatment because they're not even in a trial? So we've had a major time delay here. We've had loads and loads of research at enormous cost. We've had loads of people randomized into inferior treatments. We've had all the members of the public in their local hospital not getting access to the new treatment because everybody's waiting for the result of the trials. And nobody's doing anything about it. What a waste. So then what they did was they said, all right, let's look at this time delay. How long does it take? And this is a slightly different data set, but it's from one of their papers. Same kind of principle. So looking at studies going back to the 60s, looking at the cumulative results of all of those studies, and now what they did, what Anton did, was they actually looked to see what recommendations were going on in medical practice. And they looked at textbooks and reviews and other policy documents and classified them from saying that the treatment either wasn't mentioned at all, or it was mentioned as being experimental, or that the recommendations were that it should rarely or never be used, that it should only be used in specific circumstances, or that it should be used routinely. And we can see this gradual diffusion of recommendations through into the 90s. But what really cracks me up, see these ends? These are years when meta-analyses were actually published. So even though we've got, say, here, a meta-analysis published that year, there's still one textbook or recommendation, official recommendation, saying, oh, you should never do this. Or before not mentioning it at all, So what a waste, sorry. And if you think that's bad, those are treatments that are helpful. We've already said some treatments cause harm. And there was this class of drugs called class 1 antiarrhythmic drugs that were also used for the treatment of people who had had a heart attack. Turns out these drugs do you more harm than good. Turns out that if you give them one of these drugs, you're more likely to die. Look at this. Okay, so got all of this going on, and we're still getting people saying, oh well, yeah, you can use it under specific circumstances, or it's not mentioned at all. So not only are we having a delay for good treatments to be practiced, but we're having a delay for bad treatments to be stopped. Warm glow, doesn't it? So how then? So that's when we know that we've got enough, because we can do things like this. Every time a new study comes out, we can see how it's added to what we already know, and we can then hopefully make intelligent decisions. How do we know we've considered all of the relevant research in order to make a good decision? Well, we could have problems that individual studies are biased. I'm not going to say much about this because that's what Mona's presentation is about. So I'll leave you with bated breath there. We can have, I think, publication bias. Just because somebody does research doesn't necessarily mean that it gets published. Funded research is more likely to get published than unfunded research. Sometimes as authors, we might do a piece of research and the result is uninspiring or not what we thought it was going to be. And so we might think, it's not worth the effort writing that up. It's not going to help my career. I think I'll bother, I'm going to do something else. Or I know, I'll keep doing it until I get the result that I'm really looking for. I'll publish that one. Peer reviewers. Journal peer reviewers, unfortunately, we're all human. Journal peer reviewers, if you publish a result that is not what people were expecting or seems to contradict what people accept, peer reviewers are more likely to be critical. No, I don't believe that. Go away and do it again. No, not suitable for our journal. Editorial policies and attitudes. I don't know, 10 years ago, I was at a conference at Cochrane. And it was a nice location. And there was a panel, and the session was on bias in dental research, and they invited people to talk about bias at different stages in the research process. And I was on the panel talking about how research can be biased at the analysis phase. And the first three panelists, including myself, thought bias is a bad thing, shocking, no, mustn't do it. And then the final panelist was an editor of a journal. And he said, I think bias is a jolly good thing. I'm not interested in publishing studies that don't show something exciting. I think that if you don't get a positive result, your study just wasn't big enough. And I only publish results in my journal that got positive results and that were exciting and that the rich can be interested in. And the rest of some of them went. It happens. Not only does it happen on purpose, but it happens inadvertently as well. It's a kind of subconscious. Location bias. If you are trying to do this, trying to pull everything together, it's easier to find some studies than others. Hate to say it, but no great surprise. It turns out if you're publishing in a language other than English, much less likely that anybody's going to find it and read it. Sorry. Databases. Certain databases are more likely to be searched and incorporated than others. Citations. Some studies are easier to find than others. Some are multiple citations. And another thing that we do as scientists is this thing, multiple publications of the same data. As academics, we are driven to publish. And sometimes if we've got a study that's sufficiently large, we might slice it into several papers and get maximum value from it. And it's possible that we might be looking at the same data, albeit in a slightly different way. And if we're not careful, that ends up being hoovered up by somebody trying to do a meta-analysis. And they might, if they're not, particularly if we've been good with our colleagues and we've kind of altered the order of the authors to get everybody to go at being first author. If somebody's not really switched on, they might not know that it's all the same data, or even, particularly in clinical trials, there might be the immediate results, the 1-year results, the 3-year results, the 5-year results. It's all the same bloody patients, right? But the data just keeps going out, and people, if they're not careful, hoover all this data in and end up where, your one kind of crummy study that you've been massaging your career out of might actually end up contributing an enormous amount towards the final answer by virtue of the fact that you've done a follow-up every 3 months on these patients and published it in Notice. So, that kind of leaves some kind of food for thought around this idea of research synthesis. At worst, meta-analysis might be no better than the studies it combines, except with respect to the numbers of patients. So it's this expression, GIGO, garbage in, garbage out. Feed a whole load of rubbish in, stick it in your stew, you've got rubbish stew. Having said that, what I hope you've seen so far this morning is, whilst it is fraught with danger, not doing it, not paying attention to what already exists, is a far greater danger. So, I'm going to finish off a few little slides about how we handle research evidence in healthcare and where I'm coming from. And then I suggest we probably have a little bit of a comfort break before Mona gets down to the nitty-gritty of bias in individual studies. So, we talk about evidence-based healthcare, and it's really important to put this into context. It is not cookbook healthcare. This is Delia Smith. Delia Smith is a celebrity chef. She was one of the earlier, not the earliest, one of the earlier celebrity chefs. And she was kind of quite famous for her approach, which was quite authoritative. So Delia's book is complete. It's a complete cookery course. It is complete. It tells you everything you need to know, and you know that because it says so on the cover. It contains extensively tried and tested recipes. Delia Smith has armies of little elves that test all of her recipes for her and make sure that they are absolutely foolproof. That's true. Unlike somebody like Jamie Oliver who just chucks some stuff together and hopes for the best. This is absolutely meticulous. So it is, and it's virtually foolproof and definitely authoritative. That's cookery. Research, healthcare, is not like that. It's not that neat and tidy. You can't pick up the book and do what it says in the book and have all the answers. There's other stuff that needs to be involved as well. Now, I was talking about the Common Sense book of baby and childcare. Don't get me wrong, we mustn't ignore common sense either. Some people get really hung up on a particular research method, and they slavishly follow that method, irrespective of any reality or common sense. It bounces off them. No, my method is fabulous. Don't tell me these things. I'm obsessed with my method. Don't let common sense get in the way. And here's a wonderful example. This was published in the Christmas edition of the British Medical Journal in 2003. And it was a wonderful, wonderful paper called Parachute Use to Prevent Death and Major Trauma Related to Gravitational Challenge, a systematic review of randomized controlled trials. Their objective was to determine whether parachutes are effective in preventing major trauma related to gravitational challenge. You see, it all links back to Wile E. Coyote. Their design was a systematic review, and they were also planning to do a meta-analysis of random. They said, I am only interested in randomized controlled trials because these are the highest level of evidence. I am only interested in randomized controlled trials. So my main outcome of interest is death or major trauma. And it turns out that they were unable to find any randomized controls comparing parachute with placebo. Okay. Now, parachutes work. Most of the time. Parachutes do work. I can attest to that. When I was at university, I was in the parachute club. I have successfully done this on a number of occasions. If you'd have asked me, would I be prepared to take part in a randomized controlled trial? The answer would have been no. Otherwise, you risk being like Wile E. Coyote, jumping out of the aeroplane, putting the ripcord, and having all the washing, all the laundry coming. You see in these cartoons, all the laundry comes out instead of the parachute. So, never forget, there is a place for common sense. There's a place for recognising that no study or study design is perfect. And so, evidence-based healthcare isn't about ignoring that. So their conclusion was, as with many interventions intended to prevent ill health, the effectiveness of parachutes has not been subjected to rigorous evaluation by randomised controlled trials. And I showed this slide to some undergraduates, and they said to me, or one of them said to me, was that a real study? They were making a point. So, what evidence-based healthcare is about putting research into context. This guy, Dave Sackett, describes it as the integration of best research evidence with clinical expertise and patient values. So as a clinician, I do research, so I don't work. When I was working as a clinician, what you're supposed to do is you're supposed to look at the best evidence. You're supposed to think about your personal skills and expertise and, God forbid, what the patient wants. And when you're doing all of those three things together, when you combine those three things, when you're operating at that overlap on the Venn diagram, that is evidence-based healthcare. It is not about slavishly just following the literature. So, nearly finished. What have I talked about? I've talked about the ultimate waste of research, not making decisions based on research evidence. I've talked about the importance of research synthesis. I've shown you this technique called cumulative meta-analysis, with a recommendation that when we have the answer, we should change practice rather than just carry on. Because if we're not changing practice, what on earth are we doing? We've looked at whether or not all the relevant research evidence has been used to inform that answer. And I've had a little brief introduction to the evidence-based healthcare approach. But I've been naughty. I've been very naughty. Because there's an elephant in the room. What I haven't done in any of this is I haven't actually talked about the most important thing altogether. And I've done that deliberately because I like you to have a debate amongst yourselves during the course of your time here. Now, the biggest waste of research is to do utterly pointless research in the first place. Now, I like this cartoon. This is not in any way, shape or form a criticism of people in robotics. Not for one moment. This is merely an example of someone who has done something because they could, without for one moment thinking, why? So always ask yourself, why? Why am I doing this? It isn't just about, oh, because I could, or, oh, it looked good on my CV, and that'll help my career. Actually think about why are we doing the research in the first place? Otherwise, we're going to end up with our research being part of that 85%, which is wasted. So why am I doing research personally, and what's my priority? Well, my background is public health, and public health. There is a very famous artist in the southwest of England called Banksy. You may have heard of him. He actually allegedly lives in Bristol, but we don't know because he's a bit secretive. But he's believed to live in the southwest. And I think he summed it up beautifully here. He's got a guy here with a polystyrene cup, and the guy is saying, keep your coins, I want change. So the reason I'm doing research is because I want change. I want things to change. I want preferably to make things to change for the better. So that was me. We're okay for time. Do you want to have a comfort break and a couple before?